Good day and good evening, good afternoon, whenever you are watching this, wherever we are reaching you. Welcome to Let's Talk SADS Live, Canada. I'm your host, Dr. Shubhayan Sanatani. I'm coming to you from Vancouver and delighted to be here on this November morning. It's a special month for us here, in part because we are going to have two SADS Live talks, more about that later. And we're very excited to have a special guest. We've been talking a lot about arrhythmogenic cardiomyopathy this month, and we are going to continue that theme. So before we have our guest join us, we will just do our monthly trivia, share a fun fact. And some of you loyal fans and watchers will recognize these iconic Canadian figures, George Mines, Jenny Kidd Trout. You might be wondering why Banting and Best from Diabetes are in here, but they were Canadian Nobel Prize winners. And we talked about Tim Horton of restaurant fame. We talked about the Health Insurance Act and William Osler. We even talked when we had Dr. Hoyer, the coroner, chief coroner of Ontario. When we had him, we talked about the autopsy legislation. And today, a different format, we're going to ask you who is credited with starting the crash cart in Canadian hospitals. This is fairly difficult information to find. The crash cart is what you always see in hopefully in TV more than in your real lives. Some of you may have seen this in your real lives. It's a cart which contains, among other things, an automated external defibrillator or an external defibrillator. And so the story goes that Dr. Fred Wilson, who was a neurologist, and this is courtesy of the Heart and Stroke of Canada, he was working in the hospital in 1964, and a patient was admitted who then proceeded to have a cardiac arrest and immediately gave CPR. And this is thought to be one of the first times that CPR was given in Canada, in a Canadian hospital. I mean, the concept of of moving the chest to revive a patient is much older than that, but the formal act of CPR really has only been around since the 60s. And as you know, at the Canadian SADS Foundation and all the SADS foundations across the world, we're very pro CPR and pro AED awareness. Many of our viewers have been saved by these things. So why are we telling you about these fun facts? Well, it's really interesting, I think, to understand our history. We're going to have a little contest as well, and more details about that. But spoiler alert, you will have to be quite familiar with the trivia that I've presented, including some details about maybe when it was discussed or what episode, etc. So stay tuned. There will be a prize, probably a credit card voucher. It won't be a massive amount, so don't quit your jobs. But anyhow, stay tuned. More about that. So today I'm delighted to be hosting a emerging leader in the Canadian SADS landscape, Dr. Cadrin-Tourigny. Apologies for my pronunciation. Is an expert, international expert on arrhythmogenic cardiomyopathy. She did her training in Montreal at the Montreal Heart Institute, and then did a fellowship at Johns Hopkins in Baltimore. And those of you who are really paying attention to the trivia will remember that Sir William Osler was also instrumental in establishing Johns Hopkins as a leading facility. So please join me in welcoming Dr. Tourigny to the studio.
Hi, pleased to be here.
Yes, welcome, and thank you so much. Just to get formality out of the way, I will not try and pronounce your name. I will just call you Julia or Dr. Julia. Very informal. Thanks so much for joining us. So tell us a little bit here how you got to be this, now world expert in arrhythmogenic right ventricular cardiomyopathy.
That's a little bit intimidating. I consider that it's a big part of my work and a passion for me. And it's a bit intimidating to be called a world expert, but my passion for like arrhythmia and cardiomyopathies and genetics like developed while I was a resident in cardiology. I had the chance to meet with different patients throughout my training when I was a cardiology resident and then an EP resident, and a couple of patients with ARVC. And I thought this disease was fascinating, mainly because we didn't understand everything. It was a challenge for the diagnosis. We'll probably talk about it later, but it's hard to make the diagnosis of that disease. I felt it was not completely understood and how to treat these patients and how to decide who gets a prevention for sudden cardiac death, a defibrillator or not, was not completely, was kind of difficult and not completely understood at the time. So when I had to decide how I wanted to organize or orient my career and what I would like to do as a subspecialty of cardiology, kind of joining genetics and arrhythmia by studying electrophysiology first, which I did at Montreal Heart Institute, and then completing with an additional training in genetics, but with research centered around ARVC made a lot of sense to me because it's something that I was really interested in knowing more. So that's the reason why, after training in cardiology and electrophysiology at the Montreal Heart Institute, so part of Université de Montréal, where I did all my training, I left for Johns Hopkins Hospital to join the ARVC program there for a year and a half to learn about how they are treating these patients, but also try to work and understand more on how we should treat these patients and mainly how to stratify or decide who needs a defibrillator in this population. And after that, so I went back to Montreal, started in 2018 as an EP and also a cardiologist, member of the cardiogenetics clinic, where I see ARVC patients, cardiomyopathy patients, also neuromuscular disease patients, and patients with genetics arrhythmia.
So tell us a bit, if you know this, but Johns Hopkins has a reputation of being, a leading center in arrhythmogenic cardiomyopathy, ARVC. Does that predate? I know Dr. Calkins is a leader there. How far back does their expertise go?
I would say around 20 years. So the center started to be very interested, and this was led by Dr. Calkins at the beginning. So had an interest for ARVC, and this came from treating these patients early on and having support from families to develop a program to help treating these patients and help with research. So they started their program, they started their registry at the time, and they also developed a seminar. So every year they make this big gathering for patients and family to present the latest news about ARVC, but also develop research and develop their registry. And further in time, they started a lot of relationship with other big registries around the world, including the Dutch registry and other countries in Europe and Canada, making the collaboration bigger and this work more international.
And we've already bounced around a little bit with the name. I've bounced around from arrhythmogenic cardiomyopathy to ARVC. I'm just going to see if I can show you one more thing here, which I think is kind of fun. Let me just see if this share works. So what I'm showing, hopefully, is right ventricular dysplasia, a report of 24 adult cases. And back then, right ventricular dysplasia is a pathologic condition that primarily affects the right ventricle. So when did we stop calling it dysplasia, or what, is it two different diseases, or is ARVD really gone?
That's an interesting question. So the first the reason for the term dysplasia is because of the first understanding of this disease. So when it was first, I would say modernly described in 1982. So it has probably been described far back in the 1700s. There is a series reported by an Italian scientist, which really looks like a family with ARVC patients supported by autopsy findings. So of course, they didn't have imaging or anything fancier at the time, but it's quite likely that it was discovered back in the days. And even Osler, which we talked about, who was at McGill and also at Johns Hopkins, probably also had a case with an autopsy specimen in the library at McGill, so from the 1800s. So pushing 100 years after, in 1982, was the first modern description of the disease. And at the time, so they had these patients with dysfunctional, very dilated, very sick right ventricles. And they thought that this disease was present from birth, that it was a congenital disease. Similar to another disease, which we now know as Hall's disease, which is a congenital absence of muscle in the right ventricle. So since it was something that was deemed to be congenital, they called it dysplasia, or kind of absence or congenital dysfunction of the right ventricle. So right ventricular arrhythmogenic dysplasia. And as the knowledge on the disease evolved in the years after that, it was progressively more understood that it was a progressive disease, that people are not born, or the macroscopic changes or the change that we can see are not present from birth, but they develop with time. So this understanding led to the change in the term dysplasia to cardiomyopathy. And so both terms have been used side to side, but they basically represent exactly the same disease, but probably just an evolution in the understanding of what this disease is. And more recently, I would say in the past 10 years, the term arrhythmogenic cardiomyopathy has been used more and more to replace these two terms, or this term altogether, because we kind of understood more and more that this arrhythmogenic right ventricular cardiomyopathy did not only include the right ventricle many times. So with the evolution of imaging, for example, cardiac magnetic resonance, where we can have a better definition of fibrosis. We call it in our medical terms late gadolinium enhancement. So by injecting contrast, we can see if there's spots of fibrosis. It was more and more evident that there was, more often than we thought, some left ventricular involvement. So it seemed logical to call this disease arrhythmogenic cardiomyopathy instead of arrhythmogenic right ventricular cardiomyopathy. But this term, arrhythmogenic cardiomyopathy, became broader and broader. So some groups of experts have included way more diseases in that term, including Chagas disease or amyloidosis, while others kind of stayed centered on the genes that are causing ARVC and affect more the right ventricle. And others have also added other genes that give arrhythmia but affect only the left ventricle. So it has become a little bit confusing on what should be and what should not be included in that term. And there were guidelines published in August which kind of brought back again the term arrhythmogenic right ventricular cardiomyopathy. And as a personal opinion, I think this term is useful because it describes a specific disease, and the term arrhythmogenic cardiomyopathy might be too broad to really understand what we are talking about.
Yes, no, thank you, and I think that's helpful because people get so many different terms, and but I do agree with you that ARVC, arrhythmogenic right ventricular cardiomyopathy, is a very specific phenotype that is probably the most common of the arrhythmogenic cardiomyopathies in the SADS realm, in the genetic condition. So let's talk about that. I think one of the biggest breakthroughs really in understanding ARVC was from these very rare forms, the autosomal recessive forms that also affected the skin and the hair. So tell us a bit about that with your genetics background, the journey of genetic understanding of ARVC.
So most of the time, the vast majority of ARVC cases are autosomal dominant, which means, so genetically, we have two pairs of each chromosome. So we inherit one chromosome from each parent. So we inherit a gene, or all of these desmosomal genes from each parent. ARVC is caused by variants or mutations in genes that code for what we call desmosomes. Desmosomes are the glue or the Velcro between myocytes. So if this glue has different blocks or different components, which are all these desmosomal genes. Most of this inheritance that we get for desmosomes is autosomal dominant. So we inherit two of each components. And if we have one of the two that is deficient or working poorly, we are more at risk of developing ARVC. However, as you mentioned earlier in the days of genetics, the first genes that were discovered to cause ARVC were autosomal recessive. So a specific gene is plakoglobin. The abbreviation for that gene, because it's not that logical, is GUP or JUP. This gene was discovered on the island of Naxos, so an island in Greece where the population is very tight together. And this variant this mutation causing ARVC was way more common there in this island than anywhere else in the world. And people were more likely to have two parents with this same genetic mutation. And disease is autosomal recessive, meaning that if you get the two mutations from each of your parents, you get the disease. And this disease is more severe than it is for other autosomal dominant variants associated with ARVC. The other, as you mentioned, the other particularity of the disease of Naxos is that it's not only a cardiac manifestation or ARVC, it also causes manifestations in the hair and the skin, which was easy to see and more easy to diagnose. So it causes a thicker skin in the hands and very fine and frizzy hairs. So this was the first JUP, or plakoglobin, was the first gene found or causing ARVC. And after this one, the other that we know, PKP2, which is the most common, plakoglobin 2, desmoplakin, desmogliin, desmocolin, were all found to be associated with ARVC. So these are the classical or desmosomal genes.
And yeah, thank you. Wonderful review of that. And you mentioned the Velcro that's connecting the cells, the cardiac cells. It's interesting because I'm not aware, and perhaps you can correct me, I'm not aware that skeletal muscle is affected at all in any of the ARVC genes. Like, you don't hear about, muscle weakness. It really just seems to be a disease restricted to the heart.
Yes, exactly. So these desmosomal genes are specific to the heart. There's no muscle involvement in any of the desmosomal genes associated with ARVC. You're right.
And so if, let's say, an adult comes in with this dilated right ventricle and very abnormal rhythms, arrhythmias, they'll undergo some tests. You mentioned the MRI and the scar burden in the MRI. Are there other clinical tests that you've found very useful? I know we used to talk about these very long ECGs, these 20-minute ECGs called signal average ECGs, which I think largely have proven to be not useful. What are the clinical tests that you use in your clinic for these patients?
So that's a good question. So I would say, so you mentioned the MRI. The MRI is a very good test to see the structure of the heart, and a very precise test to see the function of the right ventricle, which is abnormal in ARVC, but also, as we talked earlier on, the presence of scar in the right or left ventricle. So this gives a lot of information. But for ARVC, unlike what we could think, it's not the first test to be abnormal usually. So usually this disease develops first as an electrical disease. And when it progresses, we come to see more and more finding on imaging. So the first test to be abnormal are very simple tests. So the 12-lead ECG, which we do all the time in clinic, which is very useful for ARVC because we see early changes on this exam. It's not necessarily a specific exam. I mean, you could have changes or anomaly on that test that is not ARVC or could be different things. But usually when someone has ARVC, this test becomes a normal first. This and another test that is very simple to have, which is called a Holter or a 48-hour monitoring, where we can monitor the amount of ectopy or the amount of myocardial excitation that we see by premature ventricular complexes, PVCs. So this gives a lot of information. So usually patients who have ARVC, when we see changes on the MRI, they usually have something on one of these two tests. They have either PVCs or either something on the ECG. And the first thing we see on the ECG is something called a T-wave inversion. So it's kind of a reversion of the relaxation of the heart that we can spot on the ECG. You mentioned the signal average ECG, which indeed was a test that was performed a lot and was part of the diagnostic criteria for ARVC. It is still part of it, but it's considered to be removed because the problem of that test, it's really it's a kind of thing in medicine where we would like it to work because it's so elegant. So the concept behind this signal average ECG test is that by looking through a machine at an electrocardiogram for a long time, you're able to remove all the noise and see very, very subtle little changes on the ECG that you could see before any other changes on, a standard, very basic 12-lead ECG. The problem with that test, it's that it's not really neither sensitive or specific. So, which means that normal people who have nothing could have an abnormal test, and abnormal people or people that are affected could have a normal test. So it's not very good to discriminate who has and who doesn't have ARVC. So we have been using it less and less throughout the past 10 years.
And so, and of course, one of the caveats as a pediatric cardiologist, very few of these findings are helpful in young people with ARVC because their ECGs are different. The T-wave inversion is normally present. They don't usually have very advanced structural or electrical disease at a young age. So pediatric is a little bit trickier unless you have a fully expressive case. The yield of genetic testing in a case, in a family or a case of ARVC, tell us a bit about that. So are we likely to find something, or?
So I would say the most classical the ARVC is, or the more classical your findings are on different exams, the more likely you are to find a genetic variant associated with ARVC. So we estimate that about 60% of the time when we see something looking like ARVC, genetic testing for one of the genes associated with ARVC will be positive. And it's also part of the diagnosis. So it's another test that we do to confirm the diagnosis, but also to help with family screening. So we were talking about different exams for the diagnosis, and I think this is important. So what is difficult with ARVC is that we don't have one single test to say someone has ARVC. even the MRI, I mean, MRI seems so elegant. So we tend to think, so if the MRI tell me it's ARVC, well, it is ARVC, but not necessarily. No test by itself is sufficient to diagnose ARVC, except for the autopsy, which of course we don't want to perform in people. So we need to put several tests together to come up with a diagnostic of the ARVC, and that's why we have what we call diagnostic criteria, which are different aspects on different exams: imaging, ECG, Holter, genetics, and family history, that put all together make us come up with a diagnostic of ARVC. So it's not like, I mean, anemia, for example. You have low red blood cell below a certain level, and I mean, it's anemia, it's nothing else. It's more complex for ARVC.
Yeah, and the scoring system or task force criteria, I think they've been reworked once, and I think they're being reworked even now as we speak. So keeping up with our advancing knowledge. Now, so 60% might find a genetic variant. So it does really mean that if you could have classic ARVC but not have a genetic marker, and then without a genetic marker, there's not really any value to checking family members for genetics, because that's not going to be informative. Now, one of the things I find there's so many things about this condition I find interesting and puzzling. A lot of people can carry a genetic variant, especially in PKP2 or plakophilin, and never develop disease. Now, one of the authors that we briefly flashed in that 1982 paper, Fontaine, he was convinced that you needed a second hit. You needed to have something, maybe myocarditis or like an inflammation of the heart, something to activate your ARVC. Has that been proven, or is that an ongoing theory?
So it's genetics and ARVC are very interesting indeed, and the genetics don't explain everything. So as you mentioned, if you're carrier of a causal variant or a mutation in one of the gene linked to ARVC, for example, PKP2 is a good example because it's the gene most often associated with ARVC, and it's the gene causing the most classical ARVC. When you want to have textbook type of ARVC, you think about plakophilin 2 or PKP2. So the penetrance is the likelihood to develop the disease if you are a carrier of a mutation in one of these genes. So the penetrance of ARVC is around 50%. So even if, for example, your father has ARVC, we find a variant or mutation in PKP2, we test you have this same mutation, your likelihood overall to develop ARVC is 50%. And then, so you were talking about this second hit hypothesis, and there are probably many things that we don't know, but one thing we are sure about for classical or desmosomal ARVC, and especially for PKP2, because this is the gene for which we have the most data, is that one important factor is exercise. So the more exercise, and especially endurance exercise, someone does, the higher the likelihood he has to develop ARVC if he or she is predisposed to ARVC through genetics. So let's say your father had ARVC, has a mutation in PKP2, you are found to have the same mutation. So if you are not someone very active, your likelihood of developing the disease is not 50%. Overall, it's probably more towards 30%. But if you are an endurance athlete, your risk increases to 80%. So exercise is clearly associated with a higher penetrance or a higher risk to develop the disease if you are at risk. Inflammation is another interesting aspect. So there might be some inflammation or viral activation. We don't have much data supporting that. It's highly plausible, but there's nothing strict in the literature that we can find proving that. However, we now more and more recognize that some genes associated with ARVC, and the most common for that is desmoplakin, that it is causing myocarditis. So desmoplakin is a cause of recurrent myocarditis, so inflammation of the muscle of the heart that manifests with chest pain, usually changes on the ECG, and elevation in troponin, so enzymes of the heart that we can detect in blood. So we see recurrent myocarditis in these in patients who are carriers of these genes, and so it's a cause of myocarditis, and it might also be a cause of deterioration of the disease.
Wow, yeah. I think it's very important at this point to say just a couple of things. First of all, the COVID vaccine was associated with a much lower occurrence of myocarditis than having COVID itself. So I just want to take the advantage to mention, there's definitely some misinformation out there. So people nowadays, when they hear myocarditis, somehow think about the COVID vaccine. So I'll strike that fallacy down. The other thing is, we are not promoting a sedentary lifestyle, because a sedentary lifestyle probably increases your risk of other conditions. So if you have inherited a risk for ARVC, we still want you to be active. We want you to discuss it with your ARVC physicians, your team, and make sure you have an exercise program, because the risks of course, other forms of heart disease far exceed your risk of ARVC if you have no exercise. So anyway, just wanted to get that out there. Now, in Canada, we have I would say, I don't like to use the word unique, because it has been seen in other populations, but essentially in Newfoundland, there is a founder mutation. So again, like this Naxos Island, a population that's fairly concentrated in their genetic makeup. And they have a very penetrant form of ARVC. So tell us a little bit about that. I know the Newfoundland must be a wonderful place, because these people do not leave Newfoundland. They stay in Newfoundland, and occasionally one will escape to Quebec or British Columbia, but mostly they stay in Newfoundland. So tell us a bit about your Newfoundland thoughts.
Yeah, so Newfoundland looks beautiful. I totally agree, and I would like to move there now. So about genetics in Newfoundland, so yes, they have this specific variant in a gene called TMEM43, TMEM43. It's not a desmosome, so it's not. So this history I was telling you about the Velcro of the heart, this gene doesn't work on the same mechanism, but it does indeed causes ARVC, but also, and this we could say it's more an arrhythmogenic cardiomyopathy, because indeed it causes ARVC, but not only ARVC, it causes left ventricular involvement with lots of ventricular arrhythmia. And it's like you were mentioning, it's a particularly severe disease. So it's more penetrant, way more penetrant than PKP2. We're way above this 50% penetrance I was talking about earlier on. And the risk of ventricular arrhythmia is much higher than for other types of ARVC. So the way we risk stratify these patients and the decisions we take to, for example, implant an ICD is different in the rest of the ARVC population. And maybe, and probably, these patients should have their own diagnostic criteria, because they seem to be a different population or a different disease than the rest of the ARVC.
Yeah, I did a little, I tried to get into understanding the TMEM43 protein, and it's interesting because it really affects cell differentiation at such a basic level. Like, it's a very highly conserved protein. And so it's remarkable that the population has, grown and grown and grown with this. And so it's almost completely widespread in Newfoundland. Now there are many interesting aspects about this. The sex predominance is particularly striking. Perhaps with the exception of Brugada syndrome, I don't think we see sex differences like this in other SADS conditions. But in the Newfoundland variant, it's 5-1 or something. Like, the females are far less affected. Have you seen this in other forms of ARVC, or is it really just mostly the Newfoundland variant?
So I would say that the discrepancy that you're describing, 5-1, is it's clearly more marked in this population. So we see a slight, I would say male sex for ARVC at large is a risk predictor for developing the disease. And if you have the disease, developing ventricular arrhythmia. So males are more at risk of ventricular arrhythmia and ARVC for different reasons. But the discrepancy between male and female is clearly more important for TMEM43. And another gene, DSP, the risk seems to be higher for female. That's another exception for ARVC.
Yeah, that's unusual. Now, you've written some very important work on risk stratification. So I don't want to leave our conversation without you telling us a little bit about that work. So, the concept of risk stratification, what do you mean, and what did you find?
So risk stratification means basically trying to predict the future, predict which are the patients who will end up having ventricular arrhythmia, in the case that interests us in ARVC. And this is important because ventricular arrhythmia, which can cause sudden cardiac death, is really the event we try to avoid in these patients. It's the highest risk of patients who have ARVC and their family members. So the goal of doing risk stratification is trying to know which patients are at higher risk and which patients are at lower risk, and decide or use that information to inform decision-making regarding the treatment we have to avoid sudden cardiac death, which is implanting a defibrillator. And I mean, we like defibrillators to prevent sudden cardiac death, but as you know, especially in pediatric cardiology, defibrillators do also come with risks of complication, especially if these people have them for a long time. So the younger you are when you get your defibrillator, the more likely you are to have your life saved by the defibrillator if you really need it, but also to have complications in the long term, including having problems with the wires that come with the defibrillator, etc. So risk stratification, the goal is to try to decide which patients are the most likely to benefit from a defibrillator and which patients should still be followed and for whom we should wait before we take the decision to implant a defibrillator. Because of course, if we decide that the risk is low and that we should not implant a defibrillator, since ARVC is a disease that evolves with time, patients need to be followed and reassessed with time with different exams. So what we basically did, so we couldn't separate the population, the ARVC people, in two different groups. The first group is easy. So if you already had a sudden cardiac arrest or sustained ventricular arrhythmia, usually the decision regarding if we should implant an ICD is pretty easy. All these patients warrant an ICD if they have ARVC. In the second case, if someone never had a sustained ventricular arrhythmia event and never had a sudden cardiac arrest, so we call this primary prevention. So the patients in whom we don't have a prior event and we need to decide based on clinical characteristics if they need an ICD. So this is more difficult. So prior to the work we did, we knew a little bit what were the predictors of ventricular arrhythmia, but we could not have an easy way to combine them. And we know that if you have different or several risk factors, if you put them all together, your risk becomes higher. So what we basically did for that population, the primary prevention patient, is finding an algorithm or a mathematical formula which enables taking all the information from the different tests someone has, so the clinical tests that are done, including the ECG, the Holter, the MRI, and putting all the information together to come up with a likelihood of having ventricular arrhythmia and helping us decide who should get an ICD at this point in time and who should be followed and reassessed over the time to decide in the future if they need an ICD.
Very important work and challenging. Now, medications in general have not been very effective with these sustained ventricular arrhythmias. I think the defibrillator makes sense, but are there any medications that work?
So I would, for the medication we have for now, we could separate the medication in two different categories. So there are arrhythmic medication, antiarrhythmic medication that can be used if people have ventricular arrhythmia. So these medication are the same that we use for all patients with ventricular arrhythmia. They include some amiodarone, maybe terms you heard, amiodarone, flecainide, sotalol. So these are medication to reduce the burden of ventricular arrhythmia. One thing we give to all patients with ARVC is beta blockers. There's not that much data specifically for ARVC patients, but since we know that it reduces the adrenergic drive, it is most likely a good thing for arrhythmia in patients with ARVC, and we usually recommend that everyone should be on a beta blocker. The other type of treatment we could think about is preventive medication that we could give to avoid the progression of the disease. And there is not much data to support specific medication that could decrease the likelihood that the heart gets weaker in ARVC. We usually use the same, if the heart gets weaker, we consider putting the same medication as for other patients with other types of cardiomyopathies.
Now, and we have little time remaining, but just sort of in one or two lines, are there some new therapies coming that you're excited about?
Yes, that's a good question, and the answer is yes. So it's quite an exciting time for ARVC right now, because two different types of therapies are now currently being studied, or studies are starting for two different types of therapies in ARVC. So there are some gene therapy projects that will probably be starting in the next year or two. And this is for now targeted mostly PKP2, plakophilin-2, which is a gene that seems to be well suited for these kind of therapy, for which the concept is basically injecting in a virus a little piece of RNA, which kind of replaces the deficient proteins in the heart. So it's kind of a little brick that is missing in the desmosome and helps rebuild the desmosomes. These therapies the studies are probably going to be starting in the next year. Pilot studies, very small studies, seeing if it works and if it is safe for patients. Another study is now starting in Canada, led by Jason Roberts, that you were mentioning earlier on. It's a study with a medication called tideglosib that has already been used in humans. It's a small molecule that seems to be affecting the pathway leading to ARVC, linking the variant in the genes to the disease in fact. And this project will be starting in Canada in the next few months. So we are probably all going to participate and are very excited about it.
Well, a wonderful conclusion to a discussion to give us a glimpse and some hope into the future. I think, ARVC is one of the most complicated conditions we deal with, right from the diagnostic workup, interpreting the tests, the risk stratification, the exercise guidance. Every step is challenging. And so we really appreciate your expertise, and you are truly internationally recognized for this expertise. So that's a wonderful achievement by your hard work. And I look forward to more conversations over the next years as we see some of these advances come into place.
Thank you so much. Thank you for having me.
Oh, our pleasure. All right. So what an informative conversation. And for those of you who are watching it at home or later on, just so much information in there. So we're going to continue on with a very exciting and important aspect of the Canadian SADS Foundation. So next week we have a special show, and I'm going to hold up this book here. I'm going to try and find it without making it too blurry there. Let's see. It's there we go. Athlete at Heart. So our guest next week is Christina Bangma, and this is a lived patient experience. And the title of the book gives a little bit away. So An Athlete at Heart. So we are looking forward to next week having a lived experience. And I'm excited to have Christina in the studio. So remember to remember about the trivia contest, and we will see you all next week. Thanks so